Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers, producer of Public Health on Call, and we want to hear from you. In more than 500 episodes since March 2020, we've been bringing you the latest on urgent public health topics like COVID-19, climate change, gun violence, monkeypox, racism, and more. We'll continue to cover these, but we'd like to know, what other public health topics would you like to hear more about? Plus, you can enter to win some amazing podcast swag, including the beach tote featured on our Twitter account. Please go to publichealth.jhu.edu/publichealthoncall/survey to take a brief survey of potential future topics. This will be open until September 9th, and that link is publichealth.jhu.edu/publichealthoncall/survey. We're excited to hear from you, and thank you so much for listening. Today, Stephanie Desmond talks to Dr. Jack Resnick Jr., the new president of the American Medical Association. They discuss the many challenges being faced by physicians and their patients in the wake of the recent Supreme Court decision allowing broad limits on abortions in many states. Let's listen. Jack Resnick, thank you so much for joining me.
Stephanie, thanks so much for having me to talk about this important topic.
So today the topic is abortion. And as president of the American Medical Association this year, this has been a topic of conversation. So I want to hear about sort of what concerns you're seeing in the wake of the Dobbs decision to overturn Roe versus Wade.
Well, one of the ways I could describe what's happening right now is more and more states have these very restrictive and confusing laws that are either being added to the books or things that have literally come back from decades or centuries past in the wake of the Dobbs decision, is that we are seeing just massive confusion and chaos in those states. We have doctors who are in emergency departments or OBGYNs who, for example, are taking care of patients who have ectopic pregnancies, where the pregnancy is not in the uterus and is not viable, and those patients have to be treated, or miscarriages where something has complicated the miscarriage, like an infection or hemorrhage, or even patients who are pregnant but need to start chemotherapy drug for cancer and need an abortion to be able to treat their life-threatening cancer. And in all of these cases, we're seeing doctors unsure that they can provide the life-saving care that they need to those patients because of these laws.
That's something that's been concerning me that I keep reading about, is that doctors might be afraid to save a woman's life.
Yeah, this is really just an egregious allowance of government into the exam room, where these decisions are incredibly complicated and difficult. And we're seeing doctors who are having to feel like a prosecutor or a state attorney general are sitting on their shoulder, second guessing the decisions that they're making and criminalizing what is really basic medical care. This puts doctors in a position where they have to really violate their own medical ethics. What drove us to medicine in the first place, thinking about what's best for the health of that patient who's sitting there in front of us on the one hand, but on the other hand, having to simultaneously think about how we're going to comply with these vague and restrictive and complicated and often conflicting state laws that are interfering. And what we're seeing is physicians in that moment literally having to call hospital attorneys to say, hey, I think this patient has a 20% chance of death right now if I don't intervene. Is that high enough for me to feel like I'm not in violation of this state law, or do I have to wait till it's 50%? Or this infection or blood infection from a miscarriage might destroy one of this patient's kidneys. Is that a big enough threat to health under these laws? These are really, really unacceptably difficult situations that doctors and patients are being put in.
And this isn't as rare as someone having each believe, is it?
No, it isn't. Ectopic pregnancies are something like 1% to 2% of all pregnancies end up being ectopic, and miscarriages are even far more common. Think about all of us really probably know a family member or a relative or a friend who's experienced a miscarriage. So these are things that are happening every day, all the time. These are not extraordinary, extreme stories. It's what doctors and patients are now facing every day in the wake of this decision and in the wake of these state laws that are restricting healthcare.
So what is a doctor to do?
Well, physicians have to follow the law because they can't risk their entire career and losing their license and having them really risking class 5 felonies in many of these states, which would involve jail time. So they are doing their best under these really difficult circumstances to provide care to the patient in front of them. And sometimes, as I mentioned, it involves those calls to attorneys, even at times when minutes or hours matter for patients' lives who are at stake. Sometimes it involves putting a patient in an ambulance and transferring them to a state if there is time where they can get the care that they need. But such large swaths of the country right now are under these restrictive laws that sometimes there isn't a close by place to send a patient to. So doctors are extremely worried, frustrated for the safety of their patients and concerned. It's a difficult time and a dangerous time.
I've read that some doctors, OBGYNs in states with restrictive laws are planning to leave the state. There's issues with training, and I'm wondering what the effects will be of this.
It's a good question. And we don't have numbers. I think it's too early to sort of judge the magnitude of this, but I've certainly heard from colleagues in some of these states, and I think it's not surprising given the immense stressors that they're under and the difficulty in providing the evidence-based high-quality healthcare that they know is right for their patients, that some of them might think about relocating to states where that isn't an issue. And I think that will only exacerbate access problems, inequities in some of these restrictive states where things can get worse. And you mentioned education. That is another piece of this. A lot of these states have medical schools and residency training programs in them. And we're worried that we're going to train a generation of physicians in the future who won't even have exposure to just basic knowledge about miscarriage management, because that will be more and more difficult to do in those states. And you'll have young people coming through training who won't have had that exposure. It's scary for the future patients who will need treatment in those states. And these types of restrictive laws, another worry of ours is from an equity standpoint, that they do tend to fall hardest on communities that are already marginalized. Wealthy patients will, in many instances, be able to travel to other places in non-emergency situations, but minoritized communities, marginalized communities don't always have those opportunities. And it really does bring up a big equity concern.
This whole idea of sort of criminalization of healthcare, it feels like a really slippery slope.
It is. And healthcare turns out to be really complicated. And the decisions that physicians are making in front of patients are difficult. And it's what we do every day, sitting down, bringing our medical knowledge to the discussion, but also talking with patients about their preferences and values and talking together about options and selecting really what is best for that patient at that time in a shared decision-making process with the patient. And when you have politicians or legislative bodies trying to firmly restrict and put boundaries around that decision-making process, it's just incredibly dangerous. And the situations that we face aren't always so simple that they fit into these state laws, even state laws that we disagree with. So it's dangerous, and it's something we're seeing in multiple areas, right? So it's not just around abortion and reproductive health care broadly, but gender affirming care, for example, for transgender teenagers, where we're seeing state legislatures in some states around the country starting to tell physicians what they can and can't do, even when some of the things that they're restricting are clearly evidence-based healthcare that is widely accepted as the standard of care by every major physician society around the country.
So this is also wreaking some havoc with certain medications that, while they're used for abortion, they are also used in other life-saving situations. Can you talk to me a little bit about that?
This is really disturbing. I happen to be a dermatologist in my day job. So there's a medication that I sometimes use for patients with psoriasis and in some rare forms of skin cancer. The medication is called methotrexate. It's also widely used in a number of other conditions, rheumatoid arthritis, lupus, several other cancers or malignancies. It just so happens methotrexate is also a very effective drug to treat ectopic pregnancies. So physicians in these restrictive states who prescribe methotrexate for a patient's arthritis, for example, are now hearing from those patients that they get to the pharmacy and the pharmacist is refusing to dispense the medication, or the pharmacy chain has set up a bunch of limitations because they're fearful of being prosecuted under these laws, even though the medication is not being used for abortion at all. And it's not just methotrexate. We're starting to see this spread even to a number of medications that might happen to cause birth defects that would end up leading to or necessitating an abortion. But even though the drugs themselves are not abortion drugs, this is really causing problems for patients with inflammatory diseases like arthritis who can't get the medications that they need. So it's on a long list of really dangerous and concerning unintended consequences that we're seeing from these laws.
And it really just depends on where you happen to live.
At the end of the day, that's right. And there are certain states that are not implementing restrictive laws like this and others that are.
Do you see physicians sort of fleeing to those states? I mean, are we going to see a huge imbalance sort of generally, do you think? Or how do you see the future?
I don't know. I think that's a real risk if some of these states don't step back and realize just how dangerous these laws are, both for physicians trying to practice evidence-based medicine and for the patients in their states. And really recognizing that these are the kinds of decisions that are best made between a patient and their physician. Abortion really is a safe, common medical procedure and an important component of reproductive health. And to the extent that states restrict both medically indicated and elective abortions, I do worry that we're going to see physicians leaving these states that are passing these restrictive laws.
Just about everything you told me so far is basically infuriating, right? It's like, how did we get into this kind of a situation? Is there anything that, regular people can do to try to make this any better for anyone?
Well, I think broadly, the population needs to speak up and say that this is unacceptable, and they need to speak up to their lawmakers at the state and federal level. At the American Medical Association, we are doing everything we can to try to mitigate some of the dangerous consequences of these laws. And I can't sugarcoat it because based on what the Supreme Court did in the Dobbs case, there is not a magic way to fix this or make these dangerous laws all go away at once. But for example, we have been working with the White House and the administration and regulatory bodies so that they hear our concerns and do things, as I said, to just try to mitigate some of the worst parts of this. For example, there's a law that's been on the books for many years called EMTALA. EMTALA really says that when patients show up at an emergency department and they're very sick and unstable or at risk of dying, that physicians have to take care of that patient right in front of them, regardless of insurance or any number of other factors. So it was very helpful, for example, to have the administration and HHS, the U.S. Department of Health and Human Services, put forward a reminder that in some ways counterbalances some of the fears that physicians and emergency departments have based on these restrictive state laws that says, hey, you have a superseding federal responsibility to provide the care that the patient in front of you needs to save their life or stabilize their health. The reality is we still have the restrictive laws on the books, and it's still really complicated as physicians are having to call hospital attorneys and work through this. But that's one of many things, in addition to thinking about the safety of patients traveling across state lines, access to medications, as you talked about, ensuring that pharmacists actually know that they're supposed to dispense properly prescribed medications for the diseases that physicians see, thinking about medical education, thinking about the privacy of patient data and everything that's in their apps and how that might be used by law enforcement, enforcing some of these very restrictive laws. So we are thinking across a broad swath of consequences at the AMA and trying to mitigate them as best we can.
Well, I wish you luck in that endeavor. Jack Resnick, thank you so much for joining me.
Stephanie, thanks for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.